2024. Nice to meet you here, all judges and the MyNEC team. So I'm Ongart from Thailand. So I'm the prosthodontist. So I work in the private hospital and the faculty hospital. So in the implant workflow, my part is the prosthetic part. So today I'd like to share my experience about the topic is about the striving beyond the comfort zone in the anterior implant challenging cases. So if we talk about the anterior implant challenges, we know that this is an aesthetic zone that we expect the display of the tooth shape, the tooth color and contour and the shape and the transparency. So in many cases of the implant placement in this area, we find some difficulty about the depth and the angulation of the implant in the anterior zone. So as a prosthodontist, what we expect in the implant prosthesis is like an aesthetic, is like a retrievability and the strength of the prosthesis. Nowadays, we have an innovation as the ASC, or that stands for the angulated screw channel that help to change the screw axis opening from the labial size to the palatal side or the lingual size. But what is an interesting question is what is a proper abutment that we should select for the ASC and in this kind of case? And today I'd like to share the points of concern of each individual cases. So the aesthetic zone, the typical bone structure we call it is a procline maxillary or alveolar bone that maybe come from some anatomical limitation, such as the different proclination of bone and the different root angulation. So when we place the implant, well, we need to concern about the angulation and the depth, such as in this case, our patient have their labial bone loss. So when we place the implants were placed palatally at the apical area for their primary stability reason. But unfortunately, the improper implant position and the angulation can be result from the bone limitation as we see. And if we talk about your ideal 3D implant position or 3D, if we see about the mesiodistal, we know the distance from the implant to implant is 4 to 3 millimeters, and implant to the adjacent teeth is 1.5 to 2. About the buccolingual or labiopalatal, the labial bone we expect at least for 1.8 to 2 millimeters, and lingual bone is 1 to 2. Somehow, the colonal apical aspect, the number is 3 to 4 millimeters from the implant platform to the gingival margin of the final restoration. So what an interesting point of the coronal apical or the depth of the implant in each cases. For the number 3 to 4 below the CEJ of the adjacent teeth or the gingival margin of the implant restoration, the purpose is for allow the adequate room for the emergence profile that we can create it for the aesthetic reason. One scientific paper that published in 2023 from Stephen Chen and team talk about the comfort zone and the danger zone. So when we see the coronal apically aspect, we see that the number 3 to 4 millimeters in the middle picture. If you go beyond that, it will go into the red zone or danger zone. And if you go below that number, maybe the implant is too shallow, or it's difficult to create the good emergence profile. So in this scientific paper, mentioned about a deeply placed implant is a common complication with the immediate implant placement. And for myself opinion, I said at the severe bone loss area, without the bone augmentation or the surgeon unable to do the good bone augmentation, the implant can go very deeply. Such as in this case, is an immediate implant placement in the tooth area 1-3. After extraction, the surgeon put the implant. And as the Dr. Stephen Chen mentioned, this is usually associated with their attempt to achieve the primary stability by driving the implant deeper in the osteotomy. So we see that in the deep implant, these advantages, including the difficult implantation for the prosthodontist as me, and very painful for the crown insertion. And you need to use the customized abutment that increasing the course of the treatment and the post-operative pain from the bone compression. So in the aesthetic zone, Today, we like to talk about the depth and the angulation. So this is my case report. Thai female, 22 years old with a non-systemic disease. Her chief complaint is about the upper anterior bridge have gap and the spacing, and she feel pain sometimes, and the spacing at the lower anterior as well. So when I take a look at the intraoral examination, we find that from tooth number 1221 is a PFM or porcelain fused to metal bridge, have a leakage margin and gap from gingival recession. And tooth number 21 had pain and positive to the percussion, and the lower teeth from 3-2 to 4-2 have a spacing. So I take the X-ray and find out tooth number 21 have the PDL widening at the apical area. So this case diagnosis is like improper processes of the 1-2 to 2-1 area, and 2-1 that have pain, we diagnosis as the irreversible pulpitis with a chronic apical periodontitis. So the lower teeth have spacing. When we take a look closer, we find out the big problem or the pain point of this case is the spacing. The patient would like to eliminate or change it, and they have pain at their front teeth to number 2-1. So my treatment plan is we need to remove the bridge at their 1-2 to 2-1 area, and 2-1 need the endodontic treatment with a prefabricated post. And after that, I will make a crown to separate like 1-2 and 2-1. And for the lower teeth, we plan for the ceramic veneers, and 1-1, we plan for the implant and the crown. So after remove the bridge and the root canal treatment, the temporal bridge was delivered, and the ceramic veneer at the tooth number 3-2 to 4-2 was done. And then my surgeon placed the implant at the 1-1 area with the GBR. And for the specification of the implant that we use is Strawman BLT, bone level taper, with the size of their diameter for 0.1 millimeters. So after 6 months, we remove the temporal bridge, and I am the prosthodontist who finding that the healing abutment that the surgeon used is like a 5 millimeter height. But with that height, I still, in the picture, we see that it's partially submerged and tilted at the labial area. And when we see the X-ray, I measure from the computer, we find that it is 5 millimeters when measured from the bone to the implant platform. So it's not a normal situation as we concern at the first glance. So after I remove the temporary bridge and put the impression coping insertion and take the X-ray, we find some interesting number in this case compared with the normal depth in the ideal position like 3 to 4. We find that the distance from the platform of implant to the CJ or gingival margin of a restoration is go up to 7 millimeters, and 4.7 millimeters is the area in the subcrestal. So we can define that this case is like a too deep implant in coronal apical aspect. So about the abutment selection that I use, because the angulation of the implant that tilts, and we need to adjust the screw opening axis. So the type of abutment that I choose is a variable base, AS. AS stands for the angle solution for the crown. So the diameter for front teeth, I select the 3.5 millimeters diameter. And unfortunately, this system provides us only 1 millimeter cuff height. So when I take impression and send to the lab, and when the crown and abutment come back to me, this is the first try in, I faced the problem that is unable to insert the abutment and the crown. The question is why? What happened? So I recognize that, okay, it's come from two mistakes. The first mistake is come from the surgeon. The depth of the implant is too deep, with the surrounding bone is an obstacle. As a prosthodontist, I see it myself mistake that I designed for the too large of the zirconia crown at the subcrestal area, and the inadequate communication with their technician. So we just know that the technician didn't know where is the bone in the stone model. So the solution is send the information of X-ray to the technician and discuss with them to solve this problem of their too large or of the diameter of zirconia abutment. So this video showed that how deep of the implant is in the stone model. So the orange line that I draw it for my technician is like and this cut with the product expert. I define it like an hourglass shape, yeah, to reduce the size of the diameter. So in this case, I still use the same variables AS abutment, but with the slimmer zirconia abutment with the respect of the bones surrounding that as an obstacle to correct the angle and deep implant position. So this is the second crown and abutment that we changed the design and the diameter of the zirconia in the stone model. And this is in the intraoral picture with the X-ray. So this is the picture intraoral that I take from the patient, from the side, and from the front wheel. So this is picture before and after. So the pain point of this case was corrected with a closer space, and patient feel more comfortable and more confident with their veneers and the crown on the natural tooth and the crown on the implant. So the point of concern when I see that the first crown and abutment, when they dissected of the first crown, I noticed something about the thickness. So the thickness of the zirconia abutment at the subcostal area is less than 0.5. So the question is, this is an adequate strength or not? With the new zirconia crown, that is slimmer. Slimmer is mean thinner. So the thickness of that area, it should be less than 0.3 millimeters. I have one experience in one case that in this case, 2-1 and 2 missing tooth with just only one implant that's placed in the 2-1 position with a cantilever pontic. 1 year of use later, patient come back with the fracture of the zirconia abutment crown at the subcostal area because it is a thin ring around the thigh base abutment, AS abutment. So about the discussion part about the aesthetic zone, when deep and angulation is a challenging issue, what abutment and retentive type of the implant crown is an ideal? For the ASC or angulated screw channel, we have two abutment type that we can use in the market. First is the pre-mill or the titanium CAD-CAM milling. The second one is a thigh-base AS. That the mechanism have like a RC-based abutment, and with the Straumann in this case is like an AS abutment. So compare with their thigh-base and zirconia abutment and the titanium CAD-CAM that anodized. About the price, the thigh-base and the zirconia abutment in Thailand is more expensive than the anodized titanium pre-mill. Aesthetics is almost the same. If we talk about the strength, some question about the thigh-base and zirconia abutment in some situation, such as in this scientific paper of the Neville in 2019. He do the seismic review in 2,231 study. He finds some 5 study report about the zirconia abutment fracture. So he said that zirconia abutment is very good for the aesthetic in the thin area of the like a phenotype, gingival phenotype, but take a risk of the mechanical complication. So he concluded that in the case of angulation, that more than the 20-degree anodized pre-mill titanium abutment should be preferred due to the better mechanical strength. So in the anterior area, the case selection is very important. And the other paper about Sakamoto, he mentioned this in 2018 about the limitation of the ASC with the thigh-base abutment. He see that insufficient space, especially in the zirconia abutment area, and the titanium metal that cause a grayish color in the thin soft tissue phenotype that in reduced ceramic thickness like a weaken the crown and the abutment. So advantage of a pre-mill abutment in this kind of case is like you can, for the titanium, you can thin it with the proper strength with the less over-contouring of the crown, and for the adequate space for the soft tissue with the subgingially go up to 1 millimeters and to gain the maximum aesthetic. So this picture show the first and second, it used a thigh base with the zirconia coping on that show the flat transition compared with the titanium CAD-CAM that you can achieve the smooth transition for the implant platform to the zirconia coping. And if you add on the anodized to change the color is more aesthetic in that case. So my conclusion is for striving beyond the comfort zone, in my case, the proper implant position and angulation should be planned to prevent the complicated fabrication. Abutment selection in deep and angulated implant position should be selected for the ASC, abutmented properly for the aesthetic, for the retrievability and mechanical strength. And the dentist and technician communication is very crucial to achieve the satisfactory. And this is my references. So I'd like to say thank you for your attention. And this is truly opening the opportunity for me to unlock my potential and test my mind about the implant planning and implant treatment. The road to Cannes for me is like a daydreaming. It's like never been come true. I never been to Cannes before, but if you believe in me and you see that I have my potential, so please, thank you very much.